So, I mean, what we will hope to do is to roll out this year.
Right.
But the rolling out will involve getting all the COEs on board, training the counselors, identifying the counselors.
Right.
So we will have to figure out whether we roll out across the country together,
right,
or roll it out in a few states and then expand it to the rest of the country. So we'll have to have discussions with the ministry about that. Otherwise, we already have a lot of content which has already been developed. We have reviewed the various tele helplines that have been successful.
Right.
Those things, some of that groundwork has already been done. We have an understanding of the flow of the whole thing. So we will be having meetings with the COEs, first with the ministry, of course.
Right.
And then with the COEs, the Centers of Excellence, so that we can get them in on the preparatory phase. Because I think the difference of this particular program is that it looks to states to have ownership of these services.
Okay. Okay.
So it's not any one organization doing it, or not the central government doing it. Every state will develop its resources.
Right. And
finally, people can be addressed in their own language. They can be counseled in their own languages. And we know where state resources are, where people can be referred to should they have a serious problem. Because that's also very important. You don't want people to travel hundreds of kilometers to get mental health care.
Right.
So that's another important thing. So for the very small union territories, for example, we will have one of the larger COEs also hand-holding that particular state or union territory, which does not have any kind of in-house capacity, which is not many at all.
Right.
Let them have one or the other capacity, but we will be looking at that. So that is what we hope to do in terms of the calendar activities coming up.
Nice. And how would people be able to avail the services in case they wanted to?
So normally what it involves is calling an IVRS, having an IVRS system where they call a toll-free number.
Mm-hmm.
And that, now so it might be a common toll-free number, but depending on which state it comes from, it will be referred to that particular state.
Right.
The counselor will answer the call.
Mm-hmm.
Will respond to the call. If the counselor is unable to handle the situation, the COE will get involved in the call. The COE basically has a specialized mental health care professional.
Mm-hmm.
And the COE and counselor, once they have evaluated the patient, if they feel that the patient needs to go to an emergency care or to an inpatient, will be able to direct the person to the particular facility, because they will have a resource mapping of all the facilities in the locality where the person is. It might be reaching a district hospital or reaching a medical college hospital, so that they can have services quickly. Very often, it takes sometimes weeks to months for people to actually access services.
Right.
So this will be a way of enhancing the speed at which people can get services. We still haven't worked out the follow-up and how the follow-up will occur. That is something we'll have to discuss with the COEs. Because at NIMHANS, we do a follow-up ourselves of all our patients.
Right.
And now we've also introduced, we are in the last phase of the pandemic, in the second wave, we had telephonic follow-up calls with our patients. Now we are trying to set up a proper technology-based solution for that.
Right.
So, that might help us in understanding how we are going to do the follow-up of people who need follow-up. Sometimes it's just a one call, I'm distressed, and the person gets okay. In which case the person may not need the follow-up. But certain people with chronic mental health conditions may need follow-up.
Right.
So we've got to figure out how best the system can do that. We still haven't worked that out.
Since NIMHANS has been running Tele-Mental helplines for a while now, how successful would you say they've been?
Okay. In fact, I was just giving the example on today's Twitter talk about tobacco cessation helpline.
Yes.
So pre-pandemic and post-pandemic, although we had a reduced number of calls, the percentage of people who registered with a serious intent to quit and who actually quit increased from 18% pre-pandemic to 40% post-pandemic. Similarly, in the psychosocial helpline, there's been a lot of feedback about how grateful people have been for actually getting that service. And you have, people from all parts of the country who've called in.
Right.
And now with the penetration of mobile telephony, everybody has a mobile phone.
Mm-hmm.
So it's actually a very useful way of, reaching people. Of course, we're aware that, even with mobile telephony, there is some inequity. Sometimes households have to share a phone.
Mm-hmm.
Women may not have access as much as men.
Right.
Young people may not have access. So these are all, but certainly it is better than having to travel 200 or 250 kilometers for a consultation. With
Absolutely.
a day's wages, have to wait in long queues.
Right.
Run out of medicine.
Right.
So I think those are all the things that this will help to circumvent.
That sounds really nice, and I think I completely agree about the fact that it will speed up the process for a lot of people.
That's right.
How long do you think this will take to ground train and set up all these centers?
So we have suggested a 3 to 5 year, time period where
right.
which will take the states to kind of be able to be entirely on their own. That's the time we're looking at.
Right. And this 3 to 5 years for the 23 centers that we're looking at right now, or is it for a more?
We're planning to do it in all the states.
Okay.
For it to roll out in all the states.
Right. And how many centers are you looking at in each state?
We're looking at one telemental health facility because it really doesn't matter where it's located. I mean, it could be located in either the district headquarters or in one, but mostly they will have to have good telephonic communication.
Okay.
So from there,
mm-hmm.
Now everything can be done online, and that's really the advantage. The
True.
COE can be connected up online.
Mm-hmm.
They can be, if people have access to a video call, it can be done through some kind of a video call facility, and that's where the Triple IT will help us to set up the technologies for that.
Right.
So, and then of course, once you have a resource mapping of what is the nearest facility, if the person did not want an alternative, you recommend the nearest facility. If the person seeks alternative, has capacity to pay, they may want to go private, you need to have a menu of various services that the person could access.
Mm-hmm, right.
So that way we can actually utilize both the public as well as the private system to help people.
Okay. I think that answers most of the questions I had.
Okay.
I just one more thing, Doctor. I just want to ask you: Do you think it's adequate, this initiative, or do you think more needs to be done?
Say that again.
Do you think it's adequate for now, or do you think more needs to be done as far as mental health goes?
To give credit to government, I think a lot has been done
mm-hmm.
in a linear fashion.
Right.
So I think this will be a game changer because of simply the reach that it will have.
Right.
But of course, a lot needs to be done. One should know. What happened was initially we were focusing on improving institutions.
Right.
And then we really reached out to develop community services.
Mm-hmm.
So everything will need to be synced together. And people need to be able to easily move from one to another. And that I think is a big challenge in all parts of the world.